Welcome to the Symposium Symposium, and as has been said, it's delivered by Julia Herbert, a focus on anorectal assessment. For those of you who don't know Julia, she's specialised in continence and pelvic health for over 35 years. She currently works in her own private practice, specialising in pelvic health. Julia's private work includes lecturing, product development and consultancy with several medical companies, one of them being Selfmedication, where she actually runs our clinical training courses on pelvic health as part of our Learning Academy. Julia's on the faculty of the ICS. She's a clinical tutor and honorary lecturer at the University of Bradford and a director of the Pelvic Health Academy. At the end, we will take a couple of questions. I have some colleagues around who will have microphones. If you've got a question, please put your hand up and we'll deal with you. If it does happen that there's too many questions, we can't deal with you, then please come along to our stand in the corner at the end. Thank you.
Thank you, Martin, who is representing Selfmedication, and thank you to Selfmedication for inviting me to speak at this symposium. And also thank you to ACA for providing the venue and the forum, and how wonderful is it that we're all here in person. It's so nice to see old friends and hopefully make some new ones while we're here. So I'm going to do a very much a whistle-stop tour through anorectal assessment and throw out some challenges. And it was quite interesting to hear the consultant talking about how they manage patients. And maybe I'm going to be a little bit controversial in the way that I'm going to present what's happening. So we're going to think about the patient journey now and thinking about patients with both fecal incontinence and constipation, whatever the reason might be for that constipation. We'll look at some of the recommended pathways, and I'm going to go back to the ICI recommendation from its last publication because the new one isn't out. But then I'm going to throw a slant on what it might look like in the UK at the moment, because that is an international recommendation. It doesn't necessarily follow what we're using in the UK. Then we're going to touch a little bit about what you might assess in an anorectal assessment and what that might tell us, and how we can actually then start to use this to benefit our patients. So there's our constipated patient, or our lady rushing to the toilet. Could be male or female, the either way round. And for many, it's a journey to the GP or self-medication. And the money that's spent is phenomenal when you look at over-the-counter laxatives and use of Imodium. So I think it's already been touched on about how taboo, talking about poo and leaking from your bowel or being constipated. So patients will often try to self-medicate, but without really understanding what's going on. We'll see adverts on the television for laxatives that you're carrying all that rubbish around in your handbag. You take the laxative and the next day it's all emptied out miraculously out of your handbag. So all laxatives are seen to work in the same way. You take them at night and you're better the next day, but we all know that there are lots of different types and patients don't understand that. What I see constantly in clinical practice is that the journey actually goes from the GP, if the patient gets there, straight to gastroenterology. And it does sound a little bit that might be the experience that's happening, where the first port of call is lots of investigations and then biofeedback comes out of that. Possibly from that gastroenterology or colorectal consultation, then they get referred to our specialist services, specialist physiotherapy or specialist nurse specialists, maybe to dietitians, and that's where the assessment can actually happen. And although I've put it as a sideline off to the right-hand side of the slide, if patients get to gastroenterology or colorectal services, often that's an automatic thing that they'll get listed for anorectal physiology and investigations. So although this is a bit of a busy slide, this was what came out from the ICI 6 that was published in 2017. And you can see here a referral coming in of a self-referral or active case finding. How often is that done? At first line, we talked right back at the first thing this morning about patients at first assessment being seen by any of our colleagues out in the community and just asking that question. Do you have any problems with your bowel? Do you have any problems with control? Do you get constipated? There's an arrow going straight across the specialist bowel services, but that doesn't often happen. And there are suggestions about what might happen in GP land, that they take a history, they do a physical exam, they look at a medication review, they maybe conduct a proctoscopy, they address the reversible factors of diet, medication, loose stool and toilet access. But we know that that doesn't happen in GP land at the moment. And I know we have a GP, I can just see out the corner of my eye, who will probably be talking more about that later. And so it's a bit disjointed, this pathway of what's happening. And what I would like to see is that patients can get straight to specialist services, that we can improve what's happening in specialist nursing and physiotherapy services, bladder and bowel health, as many of us our services are being called, and that actually patients don't have to go to hospital, that the journey doesn't have to be tortuous. I know of a trust in the northwest of England who, to actually access anorectal physiology testing, their patients have to drive down a very long motorway from the north, the west of England, down into the city of Manchester to get anorectal physiology studies conducted. Imagine that journey if you've got fecal urgency and fecal incontinence, and that's replicated around the country. So surely we can do better than that. Surely we can develop our skills and knowledge, and yes, training might be needed, and there are training courses perhaps available, and I've got a presentation tomorrow and we'll talk a little bit more about how that training might happen. And maybe patients don't have to go straight into secondary care. Really managing bowels, a lot of it can be done with conservative therapy, and we can offer that. So my arrows are all pointing into that specialist clinic. What does NICE have to say about it? Well, they say that actually adults with fecal incontinence should actually have specialised management and specialist assessment before they head for surgery. That doesn't actually say colorectal investigations before they have all that specialist assessment and specialist treatment. So that's where we should be trying to develop our services. What do they mean by specialised management? It's for people who have episodes of fecal incontinence after initial management, which may be provided by specialist continence services, which might include pelvic floor muscle training, bowel retraining, specialist dietary assessment, biofeedback, which has been mentioned before, maybe stimulation and maybe rectal irrigation. I'm not going to touch on those, but we're going to look about the assessment, digital assessment and other types of assessment, and perhaps the biofeedback element of how we can change that and offer that to patients. So, there's a paper published from the International Continence Society that writes a lot of standardisation documents, and Frawley et al. Published last year in 2021 about assessing pelvic floor function, assessing the pelvic floor, and that says that the assessor should be competent to undertake a detailed assessment. That's the first problem with anorectal. A lot of services have developed around bladder care, and a lot of people are a little bit head in the sand when it comes to bowel care. It's like, it's still taboo even for us as nurses and physios. We don't want to talk about poo, we don't want to talk about bowels. And sometimes clinicians who've come on courses with me have actually said, oh, I don't like to ask those questions because I don't know what to do with the answers. So we don't ask the question, we're never going to find the problem, but we actually need to have that skill set. So we need to develop that competency to do that, to know about the anatomy, to the physiology, what goes wrong in men and women with symptoms of pelvic floor dysfunction, and to know how to take a detailed history and then how to follow an assessment. And in the UK, we primarily use something called the Perfect assessment, but there are other assessment tools around, and there are other devices that can help to inform our assessment, and that's what I want to touch on as we move forwards. So we might look at external palpation. We might want to assess the resting tone. Is it normal? Is it increased? Is it decreased? That might be a reason why somebody can't actually poo properly. If they're hanging on like mad to their pelvic floor and their puborectalis and their deep pelvic floor is really, really tight and it's not opening the anorectal angle, that might be the actual reason why they're not going. And we don't want to be giving them an exercise program to strengthen this pelvic floor, because actually it's a dysfunctional pelvic floor. We need to do an anorectal palpation to assess for anal gaping retraction and assess the anal reflex to see if the muscles are actually working properly. We might then do an internal digital palpation. Now, I want to clarify here, because I have a bit of a bee in my bonnet about the language that we use. We have this phrase called a DRE, a digital rectal examination, and I've actually talked here about anorectal assessment, and I do think the two things are different. Lots of nursing staff will be taught how to do a DRE, to perform an examination using the anus to examine what's in the rectum, perhaps prior to giving an enema or to assess what's going on. But a full anorectal assessment is something different. It's actually looking at the functionality of the different levels of muscle in the pelvic floor and about how they're working, whether they're weak, whether they're too tight, whether they're actually dysfunctional, and what's going on. So we can actually look in females, we might actually look at a vaginal wall prolapse. So we might need to look at the front part of the pelvic floor as well as an anorectal assessment. At the back, we might be looking at the length of the anal canal. We might be looking at the deep pelvic floor muscles to assess, is that tone normal inside, to look for symmetry and atrophy and areas of sensitivity, and what the resting tone of the external anal sphincter is. So I'm not going to go through all of this slide, it's a lot of Latin names, but actually this is how Frawley splits out the pelvic floor from the anterior urogenital triangle and the posterior anal triangle. And you'll see in the posterior anal triangle that we've got the muscles pubococcygeus, including puborectalis at the back, and superficially the external anal sphincter. And those are the key areas from a muscle function point of view that we're going to look at. Now, our consultant colleague mentioned about anorectal manometry, which is actually an anorectal physiology assessment of a pressure measurement. And it's done in different ways. So the equipment that was in the slides previously was showing you a water perfuse system with jets of water coming out that measure the pressure reaction. So these first three devices bulleted here, the microballoon system, water perfused catheters and solid state catheters, in the main are going to be found in physiology departments where patients will have to travel to get those assessments done. There are, however, products that we can use in clinic, so nurses and physios can learn how to use equipment to assess from a physiological point of view what's happening to get a more objective assessment. So things like an Evo 4C, which has an air-filled balloon, or the Eurostim from Laborie, which has an air-filled balloon. There's a device called Anopress, which again has an air-filled balloon, which will give you also a rectal balloon so you can see how the rectum's behaving. Now, those first three devices are actually measuring pressure with manometry, so it's air inside a balloon, so it's giving you an average of what's going on. And another device that's actually about to go to market, it's just waiting for regulatory final approval, is an anal probe with pressure sensors that are going to be on it, with 12 sensors that will measure directionally front, back, left, right, and also what's happening in the rectum. So there's more information about that product that will be available on the DeSmit Medical stand if you would care to have a look at that later on. What are we looking at then if we're looking at using a device? Well, rather handily, this paper was published back in 2019, which is trying to get the international colorectal community to standardise what things we test when we do use equipment. So we can look at the resting pressure over a minute. That will tell us what the internal sphincter's doing. So is it actually closing that bottom off properly? Can the patient volitionally squeeze their anal sphincter when they're asked to? And we need a sensor that is actually able to pick that up. How long can they hold a squeeze for? If you've got urgency and you need to defer going to the toilet, you need to be able to do at least a gentle squeeze of your anal sphincter to defer the urge that lasts up to 10 seconds, maybe slightly less in some patients. So we can assess that objectively if we have the right kind of equipment to do that. Can the patient coordinate short, quick squeezes? What happens if they cough? Does it come in, or does it just ignore the fact that the pressure's gone up in the abdomen and something could leak out? We tend to talk about stress incontinence with urinary stress incontinence, but some patients actually get fecal stress incontinence. So we need that cough reflex there in the anal canal. Now, I haven't time today to go through this next bit, which is the recto-anal inhibitory reflex. It's actually called rare, but it's not rare at all if we spelt it the other way, because it happens frequently throughout the day. And that's where the bottom is sensing something landing in the rectum and the sphincters are behaving automatically. And that's quite an interesting reflex to understand when we look at Kath's slides that she was talking about abuse and anal sex, because that's maybe going against how that reflex should work. So if we have the right equipment, we can test whether that's intact tract and whether that's working properly. Some of us are already using a simple balloon catheter that was developed by St Mark's Hospital with Professor Norton as originally a urinary catheter with literally a party balloon tied on with black cotton. That progressed into being a proper catheter that was produced by a company for us that we could test rectal sensation. But now there are products, the Anopress and the Anosysco, that actually have that balloon device built into it. So in our own clinics, as specialist nurses and physiotherapists, we would be able to assess somebody's ability to detect what's in their rectum and then use that as a training facility with biofeedback to get them to learn how to defer going to the toilet and treat that problem of fecal urgency and incontinence. And likewise, with that same balloon, if you have the availability of that, you can assess for defecation ability. So somebody with obstructed defecation who's not releasing their muscles properly and can't actually push stool out, then we can actually use balloon expulsion, so using the same balloon but for a different group of patients. So if we're looking at that resting pressure, it would be the middle of the anal canal. If we look at the outside to the right-hand side and the balloon is sitting along the anal canal, or our pressure transducers are reading what's happening, then we can read if there's decreased resting pressure. That would lead to passive incontinence, flatal incontinence. Maybe high resting pressure would be leading to difficult defecation, and that might be suggestive that that external anal sphincter, the outer flower pot, I love the flower pot, so I'm going to pinch that one. So that outer muscle was actually squeezing too much, and that's why somebody can't poo properly. So we can see where that pressure sits and have a range of what we would expect that to be. We could measure when they squeeze, so can we see that volitional squeeze? What's happening? We can measure that rectoanal inhibitory reflex, a reflex relaxation of the internal sphincter in response to filling up the rectum. So we have to have a balloon on the end of our device to be able to test for that. Not all equipment is able to do that. And actually an absence of that reflex is indicative of Hershburns disease, and it's quite rarely diagnosed in adults, but it can actually be missed in childhood and is a disease where there's no sensory nerve endings in the rectum that tell you when it's filling. That's what we should see. So if we have a device that has a graph, then we should see on the screen. And we can explain that to patients, so that becomes therapeutic because patients can see it from a biofeedback effect that things are working properly. If we use the balloon with a syringe with air in it, we can inflate the air and mimic a poo landing in the rectum. And there are certain normative values of when you would expect to feel something arriving in the rectum. And an example of this was a patient I often use as a case study when I'm teaching, a lady with Crohn's disease who was quite stable with her Crohn's, but actually was having terrible episodes of fecal urgency and fecal incontinence. And her threshold when it was tested in the physiology lab with urgency was actually at 10 mils. Now, if you look there, the normal onset of sensation of like, oh, there's something happening in my rectum is normally around 40 to 50 mils, but she was getting terrible urgency. I'm going to have an accident with only 10 mils. And by using a device similar to these devices I've just described, we were able to retrain her sphincter to work better and her to stop panicking when she got these feelings. And although we only got her to a tolerance of 50 mils before she got urgency, it completely changed her life. And we had a lovely outcome measure called the Tesco outcome measure, because her accidents had happened in the freezer aisle in Tesco's. And the outcome measure with her was that with the training, with anal sphincter biofeedback and with rectal sensation down training, basically, we were getting her not to panic when she got this sensation. She was able to get through the freezer aisle, finish all her shopping and put it all away in the car with her 3 children and then go to the loo. So it can really help. So we've got that reference there of assessment protocols. So if you're looking to get some equipment to use to expand your practice, and remember that patients who come to your clinic with urinary incontinence, around about 40 to 50% of them might also have fecal incontinence or constipation issues. It's not rare, it's not uncommon, it's just not talked about. So we need to be ready, we need to be offering a better service to these patients, and maybe we can start to do some of this investigation in our own clinics and support those patients and turn those assessment findings into therapy protocols using the biofeedback programs that are available on these bits of equipment. And we can actually train the patient how to hold on to their sphincter. So many patients with fecal urgency have fantastic gluteal muscles. Kim Kardashian would have nothing on them. They can squeeze to their heart's content, because actually, if you squeeze your bum together with your cheeks of your bottom, it closes the very end of your anal canal, but it doesn't use that reflex. It doesn't inhibit what's going on in your rectum. It doesn't get reverse peristalsis. So teaching patients how to visualise their own sphincter, have belief in self-efficacy, that they can do something about this problem and get back in the driving seat, is amazing. So I would challenge you all to learn a little bit more about anorectal if you're not already doing it, or have a look around at what training courses are available, have a look around at what equipment is, and as I say, there is some equipment that's going to be launched soon that's on the Dismit Medical stand. So I can't see a clock from here because it's in shade, but I hope I haven't overrun, and so we're going to take some questions.
It's perfect time, and time for some questions.
My final slide, just to remind you that it could be worse than talking about poo. If you look carefully, he's actually washing the other side of the elephant. It's not what you thought. So, Martin, I'm going to get you to moderate the questions.
Kick you off with a question, not kick you off, but start off with a question.
No, you can't kick me off.
What are the differences between the different types of devices that are used to do this type of assessment?
Okay, so the ones that we were talking about in physiology clinics generally are either solid-state catheters, so electrically measuring the pressure changes in the anal canal, or they're water-perfused systems. So you have 8 channels or 12 channels. There are some amazing ones that have over 200 channels that are very, very expensive. And they have to be actually cleaned in between patients because they're not easy to recycle. But they will measure along the length of the anal canal what's going on with the sphincter and also what's going on in the rectum. So they'll tell you the rectal pressure. The other devices I mentioned, like the Evo 4 and the Eurostim, have a very basic one single balloon that's just put in the anal canal. It'll give you an average. It will be better than using EMG to measure. I don't know whether you've heard of EMG, electromyography, just detects the signal coming from the muscles, but it can't tell you what the internal sphincter is doing. It won't give you any resting pressure reading. It won't tell you how good or bad the internal sphincter is. So we would use a pressure catheter, but the basic biofeedback systems that exist at the moment have just a single balloon, as does the Anapress, but the difference with the Anapress, it has a rectal balloon as well. The new one, Anosys Go, will have pressure transducers, so solid-state transducers, and it will have 12 of those arranged front to back, side to side, and one on that can measure rectal pressure as well. So it will give you quite a lot more information than we've been able to obtain before, but it's designed to be really simple. I can't tell you too much about it in here. Please go and have a look. There's one on the stand, a prototype that's not out for clinical use yet, but hopefully very, very soon it's going to be available for us all to get very excited about. Are there any other questions?
No questions at all. Okay. Would you rather people came and found you?
In fact, yeah, I'm going to go down to the stand over the tea break, so you can all have a slightly earlier tea break if you would wish to, and if you don't want to ask it in public forum in here, I'll be on the stand, as will with some of the Dismit team as well, who can deal with your questions there.
Thank you, Julia.
Thank you.